Let's begin by understanding what a heart murmur actually is. A heart murmur is defined as a relatively prolonged series of audible vibrations heard during the cardiac cycle. These sounds are produced by turbulent blood flow within the heart or great vessels, creating vibrations that can be picked up with a stethoscope. Murmurs are characterized by their timing within the cardiac cycle, their intensity or loudness, frequency or pitch, quality, configuration, duration, and the direction in which they radiate. Understanding these characteristics is crucial for accurate diagnosis and management. Murmurs are produced when turbulence is generated in the blood column. This turbulence sets up vibrations in the vessel walls and cardiac structures, which are then heard as murmurs. The sound is essentially a result of blood moving through the heart in a way that is not completely smooth, often due to high flow, small orifices, or changes in blood viscosity. These vibrations can be picked up during a physical examination, providing important clues about underlying cardiac condition. Understand why turbulence occurs. We look at the Reynolds number, a mathematical formula that predicts when blood flow will become turbulent. When the Reynolds number exceeds 4,000, turbulence is likely. Factors like the internal diameter of vessels, blood velocity, and viscosity all play a role. Turbulent flow is what generates the vibrations that become murmurs, so understanding these physical principles helps explain why murmurs are present in certain heart conditions. Auscultation is the process of listening to heart sounds with a stethoscope. The quality of auscultation depends on several factors, including the distance from the chest wall, the position of the patient, underlying tissues, and the quality of the stethoscope. Proper technique is essential for accurately identifying and characterizing murmurs. By carefully listening at specific locations on the chest, clinicians can gather valuable information about the type and cause of a murmur. Understanding the anatomy of the heart valves is crucial for interpreting murmurs. The heart contains four main valves: the aortic, pulmonary, tricuspid, and mitral valves. Each valve has a specific location and function, and murmurs are often best heard at certain points on the chest that correspond to these valves. Knowing where to listen helps clinicians pinpoint the source of abnormal sounds and guides further evaluation. Describing a murmur, several features are important: its position in the cardiac cycle, the site where it is loudest, its intensity, quality, pitch, conduction, and any dynamic changes. These characteristics help differentiate between various types of murmurs and their underlying causes. For example, a murmur that occurs during systole may suggest a different pathology than one heard during diastole. Murmurs are classified based on when they occur in the cardiac cycle. Systolic murmurs happen between the first and second heart sounds, while diastolic murmurs occur after the second heart sound. Some murmurs are continuous, spanning both systole and diastole. Recognizing the timing helps narrow down the possible causes and directs further investigation. Site where a murmur is loudest can provide important diagnostic clues. For example, murmurs heard best at the apex may suggest mitral valve disease, while those at the left lower sternal border could indicate tricuspid or ventricular septal defects. Careful auscultation at different chest locations helps localize the source of the murmur. Murmur intensity is graded using the Freeman and Levine system, ranging from grade 1, faintest, barely audible, to grade 6, heard with the stethoscope off the chest. This grading helps standardize descriptions and allows for consistent communication among healthcare providers. The presence of a palpable thrill usually indicates a grade 4 or higher murmur. Quality and pitch of a murmur depend on the pressure gradient across the valve and the amount of blood flow. Low-pitched murmurs are often described as rumbling, while high-pitched murmurs may be blowing or harsh. These characteristics can help differentiate between conditions like mitral stenosis and aortic regurgitation. Some murmurs radiate to other areas of the chest or back. For example, mitral regurgitation murmurs often radiate to the axilla, while aortic stenosis murmurs may be heard in the carotids. The direction of radiation can provide valuable diagnostic information and help distinguish between different types of murmurs. Murmurs are classified into systolic, diastolic, and continuous types. Systolic murmurs occur during ventricular contraction, diastolic murmurs during relaxation, and continuous murmurs span both phases. Each type has its own set of possible causes and clinical implications, making accurate classification essential for proper management. Systolic murmurs are further divided into mid-systolic, holosystolic, early systolic, and late systolic types. Mid-systolic murmurs are the most common and can be either pathological or innocent. Holosystolic murmurs last throughout systole, while early and late systolic murmurs occur at the beginning or end of systole, respectively. Mid-systolic murmurs start after the first heart sound and end before the second. They can be caused by ventricular outflow obstruction, dilation of the aorta or pulmonary trunk, accelerated systolic flow, or even be innocent. Recognizing the setting helps determine whether the murmur is benign or indicative of disease. One common cause of mid-systolic murmurs is ventricular outflow obstruction, such as aortic stenosis. This condition creates a harsh crescendo-decrescendo murmur due to turbulent flow across the narrowed valve. The murmur's characteristics, including its timing and radiation, help distinguish it from other types. The murmur of aortic stenosis is typically harsh and has a crescendo-decrescendo pattern. It is best heard at the right upper sternal border and often radiates to the carotids. The length and loudness of the murmur can provide clues about the severity of the stenosis, but other features must also be considered. Galliverton phenomenon refers to the presence of a musical murmur at the apex, which can be mistaken for mitral regurgitation, but is actually due to aortic stenosis. Differentiating between these murmurs is important, as their management differs significantly. Careful auscultation and attention to associated findings are key. Hypertrophic obstructive cardiomyopathy, HOCM, is another cause of mid-systolic murmurs. In HOCM, the left ventricular outflow tract becomes dynamically obstructed, especially during conditions that increase contractility or decrease ventricular volume. Maneuvers like standing or Valsalva can accentuate the murmur, helping to distinguish it from other causes. Pulmonary stenosis produces a mid-systolic murmur that is best heard at the left upper sternal border. As the severity increases, the murmur becomes longer and may engulf the second heart sound. Associated findings such as a widened split S2 or a soft P2 can provide additional clues to the diagnosis. Not all mid-systolic murmurs are due to valve obstruction. Dilation of the aorta or pulmonary trunk, as seen in Marfan's syndrome or pulmonary hypertension, can also produce these murmurs. Increased flow states, such as anemia or pregnancy, may cause innocent mid-systolic murmurs as well. Some murmurs are considered physiological or innocent, meaning they are not associated with structural heart disease. Examples include Still's murmur, pulmonary mid-systolic murmur, and supraclavicular systolic murmur. These murmurs are usually soft, short, and do not radiate widely. They often disappear with age or changes in body position. Still's murmur is a classic example of an innocent murmur in children. It is described as a short buzzing sound similar to the twanging of a rubber band. This murmur is caused by periodic vibrations of the pulmonic leaflets and is considered harmless, usually resolving as the child grows. Pulmonary mid-systolic and peripheral pulmonary murmurs are also considered innocent. They result from angulation and disparity between the pulmonary trunk and its branches, causing turbulent flow. These murmurs typically disappear as the pulmonary bed matures. Supraclavicular or brachiocephalic systolic murmur originates from the aortic origins of major arteries. It is characterized by a crescendo-decrescendo pattern and is often softer below the clavicle. This murmur can be distinguished from pathological murmurs by its response to shoulder abduction. The mammary souffle is a continuous murmur heard in late pregnancy or during lactation. It is louder in systole and can be augmented by light pressure. Firm pressure, however, abolishes the murmur. This finding is benign and related to increased blood flow in the mammary arteries. Holosystolic or pansystolic murmurs last throughout the entire systole. They are typically caused by conditions where blood flows from a high-pressure chamber to a low-pressure chamber, such as mitral regurgitation, tricuspid regurgitation, or ventricular septal defect. These murmurs are usually high-pitched and may radiate widely. Mitral regurgitation produces a holosystolic murmur that begins with the first heart sound and continues to the second. It is best heard at the apex and often radiates to the axilla or back. The murmur's intensity and radiation depend on the direction of the regurgitant jet. Tricuspid regurgitation also causes a holosystolic murmur, typically heard at the left lower sternal border. The murmur increases with inspiration, a finding known as Rivero-Carvalho's sign. This helps distinguish tricuspid regurgitation from other causes of holosystolic murmurs. Ventricular septal defect (VSD) creates a holosystolic murmur due to blood flowing from the left to the right ventricle. The murmur's characteristics depend on the size and location of the defect, as well as the pressure gradient between the ventricles. Large defects may also produce additional murmurs. Acute mitral regurgitation produces a decrescendo systolic murmur as the left atrium cannot accommodate the sudden increase in volume. The murmur is loudest early in systole and diminishes toward the end. This pattern helps distinguish acute from chronic mitral regurgitation. Mitral valve prolapse (MVP) is characterized by a late systolic murmur, often preceded by one or more mid-systolic clicks. The murmur's length and intensity can change with body position or maneuvers like standing or squatting, which alter ventricular volume. Diastolic murmurs occur after the second heart sound and are divided into early, mid, and late diastolic types. Early diastolic murmurs are typically due to regurgitation through the aortic or pulmonary valves, while mid and late diastolic murmurs often result from stenosis of the atrioventricular valves. Aortic regurgitation produces a soft, high-frequency early diastolic murmur, best heard with the patient sitting and leaning forward in full expiration. The murmur is usually heard at the left sternal border and may have a musical quality, especially in cases of valve eversion. Pulmonary regurgitation, especially in the setting of pulmonary hypertension, produces a high-pitched, blowing decrescendo murmur known as the Graham-Steele murmur. It is best heard at the left upper sternal border and is associated with a loud P2. The murmur's features help distinguish it from aortic regurgitation. Mid-diastolic murmurs begin after a clear interval following the second heart sound. They are often due to stenosis of the mitral or tricuspid valves or increased flow across these valves. The classic example is the low-pitched rumbling murmur of mitral stenosis, best heard at the apex. Mitral stenosis produces a low-frequency, rough, rumbling mid-diastolic murmur, best heard at the apex with the patient in the left lateral position. The length of the murmur correlates with severity, and late diastolic accentuation is often seen in patients with normal sinus rhythm. Tricuspid stenosis produces a murmur similar to mitral stenosis but is best heard at the left lower sternal border. The murmur increases during inspiration, reflecting the increased flow across the tricuspid valve with each breath. This finding helps distinguish it from mitral stenosis. The Austin Flint murmur is a mid-diastolic murmur heard at the apex in severe aortic regurgitation. It is caused by the regurgitant jet striking the anterior mitral leaflet, preventing it from opening fully. This murmur can be differentiated from mitral stenosis by the absence of an opening snap and other features. Other diastolic murmurs include the Carey-Coombs murmur of acute rheumatic fever, the Cabot-Lock murmur in anemia, and Dock's murmur due to coronary artery stenosis. Each has unique features and clinical associations, highlighting the importance of a thorough evaluation. Continuous murmurs begin in systole and continue without interruption through the second heart sound into diastole. They are caused by abnormal connections between high and low pressure chambers or vessels, such as patent ductus arteriosus, aortopulmonary window, or arteriovenous fistulas. Patent ductus arteriosus PDA produces a classic continuous machinery murmur, best heard at the left upper sternal border. The murmur peaks around the second heart sound and may be accompanied by other findings depending on the size of the ductus and the presence of pulmonary hypertension. Other causes of continuous murmurs include aortopulmonary window, ruptured sinus of Valsalva, and coronary arteriovenous fistulas. The location and quality of the murmur, along with associated clinical findings, help differentiate between these conditions. A venous hum is a continuous murmur heard over the medial aspect of the right supraclavicular fossa, especially in children and pregnant women. It is louder in diastole and can be obliterated by compressing the internal jugular vein. This benign finding is due to rapid blood flow in the veins. Dynamic auscultation involves altering circulatory dynamics through maneuvers like changing position, valsalva, or hand grip to observe their effects on heart murmurs. These maneuvers can help distinguish between different types of murmurs and provide additional diagnostic information. Summary: heart murmurs are complex sounds produced by turbulent blood flow within the heart or great vessels. Their timing, location, intensity, and quality provide valuable clues to underlying cardiac conditions. Careful auscultation combined with dynamic maneuvers and a thorough understanding of cardiac physiology is essential for accurate diagnosis and management. By mastering these principles, clinicians can effectively evaluate and treat patients with heart murmur.